following is a production of West Virginia Public Broadcasting.
Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University. Welcome to Doctors on Call. Tonight's topic, women's health. Two experts are here to answer your questions. Now here's your host, Dr. Kathy Moffitt.
Good evening. From puberty to pregnancy, menopause to old age, a woman's body is constantly changing. So are her health needs. It can be a challenge to keep up and stay healthy. What forms of birth control is right for you? How can you ensure a healthy pregnancy? Should you consider hormone replacement therapy after menopause? We'll get answers to those questions and more tonight from our two guests, Dr. Charles Hochberg, an obstetrician and gynecologist at WVU who specializes in high-risk pregnancy, and certified nurse midwife Stacy Archer, who's director of midwifery services at WVU. If you'd like to ask our guests a question, give us a call. Our phone lines are now open. So Charles, the guidelines for hormone replacement therapy have kind of changed over the years. Where are we today?
I think we learned to individualize the care when it comes to a patient who's in transitional menopause or in the menopause. After the Women's Health Initiative came out, I think everybody was terrified of putting someone on estrogens, when it is still the major way of preventing the symptoms of going through menopause. After looking back on the data that came from that study, we realized there are a lot of mistakes made. First of all, the average age of the patient in that study was 63. I have difficulty thinking about the last time I started someone on a hormone therapy at 63. It's usually started in women in their 40s or maybe 50. So the age group was much older than we really like to deal with. And looking back on the exact same data that they presented originally, they discovered that in the first 5 years of replacement therapy, the complications that were frightening patients, the heart disease, the strokes, the breast cancers, were just not there. Right. So certainly for the first 5 years of going through difficult times of menopause, you can feel comfortable after seeing your physician and going over the complications and the doses to probably do very nicely on hormone therapy.
Right. So Stacy, let's talk about the evolving role of a midwife in women's health. These are really important topics. How does a midwife fit in with the care of women?
We work directly with physicians to give care for women throughout the lifespan, through the teenage years, through the perimenopause to menopause years. I think very often people think of us as providers of prenatal care, which many of us love and are proficient at. Antepartum care is is a forte of mine, and then following a woman through the pregnancy and the labor and the delivery.
So I think of a nurse midwife as delivering babies, but it's more than that. It's following this woman then postpartum, and then when she's done having her children, and following them throughout their life.
Absolutely.
And recognizing then the normal things, and then also recognizing some of the things that they may need referral then to an obstetrician or gynecologist.
Yes, or other partners in the health care team, whether it's a high-risk physician or someone that specializes in diabetes or hypertension.
Right. So all those good health screenings. So let's go back to menopause and talking about the symptoms. I've heard the term perimenopause, menopause. Is there a time when a woman starts to go through this but still having periods, still can get pregnant, or what?
Yeah, it's referred to as a transitional period of time, and it's when the women will still ovulate, so they still need contraception. Mm-hmm. And probably are more frightened about getting pregnant when they're 50 than they were 27, so It's a scary time. The other thing that occurs is they may be having fluctuation in their estrogen levels, so they may very well be getting symptoms but periods. And very often the patients will go to the doctor and he'll ask, are you having periods? And the answer will be yes. He says, well, it can't be, your problem can't be menopause then. And the women will respond with, I'm having difficulty sleeping, I'm having difficulty at work, I'm forgetting things, I'm falling asleep at my desk, my coworkers think I'm not doing my job. And the doctor says, well, I think it's time to put you on some antidepressant. The fact is they may be in transitional menopause and they're having sleep disturbances. They don't sleep at the same deep level of sleep, so they are tired the next day and they don't perform well. And all they may need is a little supplement to their hormones. So even though you may be having periods, you still may be in transition, which averages 6 months to 5 years. So if you stop menstruating at 50, you may have these symptoms at 45 or 43. And so you have to seriously consider that and be worked up that this may be a simple treatment rather than getting into complex neurotransmitters and all kinds of tranquilizers and so forth.
So we have a caller, Candace from Taylor County. Hi, Candace. Go ahead. What's your question?
Hi. My question is, I turned. Do you hear that? Okay. I turned 60 in May, and I stopped menstruating probably 6, 8 years ago. And I wonder, is it too late to take hormone replacement? Would it help me now? I just had total hip replacement, and I wonder if it would make my bones stronger, or is it too late to start on a hormone therapy now at 60?
So at age 60, she's not been having periods for 5 or 8 years, quite a while. Is it too late?
It depends. Well, there's ways of delivering hormones, not necessarily orally. If the patient is not having vasomotor changes or hot flashes, she probably should not be started on oral estrogens at the age of 60, certainly not for the first time. If she's having the other symptoms of estrogen withdrawal, the most common being vaginal atrophy, difficulty with sexual relations, then for sure she becomes a candidate for topical estrogens, which works beautifully. So yes, she's a candidate for estrogen, although it may not be oral estrogen. As far as her bones are concerned, hormone replacement therapy will improve your bone mass, but it's certainly not advocated as the primary treatment. So I would not start somebody because they have osteopenia or osteoporosis on estrogen at age 60 and think that I'm really accomplishing much. I would much rather go to more appropriate medications.
So what women and bone health in women, what do you recommend women do about calcium, vitamin D? When do they get screened for osteoporosis with a DEXA scan?
Of course, starting young and getting plenty of exercise, eating a diet rich in calcium, and taking calcium supplements, 12 to 1,500 milligrams a day has been the recommendation. Beginning it in their teens through their adult years, and starting good health habits early.
So exercise is good to make your bones strong, keep them strong.
Weight-bearing exercise
and then making
key.
sure you're getting a lot of calcium. Do you have an age when you consider a DEXA scan, or does it depend on family history?
Well, the latest, a DEXA scan just gives you a number. It doesn't tell you your risk to having a broken bone. So I advise every woman who's had a DEXA done is to call back her physician and say, I need you to look at a FRAX, F-R-A-X, and tell me if I'm at risk for a fracture. You can do the FRAX yourself. You just go on Google and look up FRAX computer, and you'll be plugging in all kinds of numbers and come up with a number, and the number will tell you whether you are prone to fracture. If your fracture risk to a hip fracture is greater than 3% over the next 10 years, you have to be treated with pharmacologic agents. If your risk to breaking some other bone is greater than 20% in the next 10 years, you also should be treated with things like bisphosphonates.
Right, and so the role of estrogen is important in a woman's lifetime, but if you already have a risk for breaking a bone, it's not estrogen that you need necessarily.
Correct.
It's the other medications that help make your bones hold on.
Or certainly you need... Right, a combination. The key is that I always think about bones as being sort of like building a house. You need raw materials, and then you need a contractor. If you brought all the materials to my property now, you would not get a house. I have no idea how to build it. I need a contractor. So the contractor can be a whole bunch of things. It could be exercise, it could be bisphosphonates, it could be SERMs or things called selective estrogen receptor modulators. So there are a lot of contractors out there. The raw materials for your house is calcium and vitamin D.
So if you don't get dairy in your diet, then or calcium, then you need those raw sardines or whatever, the sardines with bones.
Superb, yes.
But most of us aren't eating those, so you need to get the calcium.
Yes.
So we have another caller, Barb in Marshall County. Hi, Barb. Go ahead. What's your question?
Hi, how are you?
Good.
Hi, I had a question. Well, actually, I came up with two questions. One of them, if someone is seeking hormonal replacement therapy, would you start out on a pill, or would you decide maybe use an S ring?
Okay.
And that's vaginal insertion. And then the other question I had: do you not still produce estrogen from your ovaries, even if you postmenopausal, and also your pituitary? So you're still producing estrogen, but a very low amount.
Right. So the first is, what's the best way to get the estrogen?
It depends. The S ring, which was mentioned by the caller, is very good for replacement therapy to the vaginal tissues itself. There's very little absorption and will probably not be beneficial to a woman that's still having vasomotor changes and hot flashes or sleep disturbances.
Right.
There I would go to either an oral route or a transdermal route in the form of a patch or something of that nature.
Okay.
Yes, your ovaries still make small amount of estrogens even though you're postmenopausal. It's called estrone, which is a very weak estrogen, but it's estrogen nonetheless. The problems we have is not your ovaries making small amount of estrogens as you're postmenopausal. The problem we have is in our population, especially in places like here in West Virginia, where we have so many women that are overweight. If you're overweight, what you do is you take a neutral steroid that comes from your adrenal gland and you put it back into your body fat, and it's aromatized or it's changed into a very potent estrogen once again. And it goes back into circulation and can circulate back to the uterus, which increases the risk of a woman having endometrial or uterine cancer. So the estrone is weak, but the estrogen produced by body fat when it reconverts neutral steroids is the one we are most concerned about in our heavy population.
So another reason why exercise, diet, losing weight is really
very important.
Really important. Now, there are some other issues that women face after they've gone through menopause. A lot of women have a lot of urinary incontinence. Is this a common thing that you see in your older women population?
Yes, people that may have stress incontinence, which may be either treated surgically or through pelvic floor exercises. So, of course, those are they are given instructions during their annual exams.
And are those women? Is it more likely if you've had children, or is it all women?
I believe all women.
All women.
Maybe your a vaginal delivery might increase your chances of that, but all women as they age are at risk for that.
So we really do. We have a lot of changes that go on.
I'd just like to bring up to our listeners that the fact is that leaking of urine is not normal. And what has happened is it's sort of been, because our population is getting so much older, sort of kind of cute, you know?
Right,
When
you laugh
see
and
the
then,
lady, you laugh and you leak and say, oh, I just had an. But it is not normal to do that, and it can be helped. And many times it is not a surgical approach. So the distal part of the urethra, the tube where you urinate, is the same tissue as the vagina embryologically. And just like the vagina dries, the distal part of the urethra undergoes changes, the very end part. And so you may have some leaking. It's usually that slight leaking, and it can be treated. So, and that's treated medically. So that there are a lot of these situations which are not pleasant, and I don't think women should have to accept that.
So it's not just going to the gynecologist for a pap smear, which is very important, but as you age, there are other things that you'll ask about, that you inquire about, that you can do things about.
Absolutely.
Now, we've had changes recently because we have the HPV vaccine and hopefully prevention of the majority of infection from HPV, but the recommendation for pap smears is still the same. All women should undergo, but the age has been raised a little bit, from what I remember.
Stacey and I both start pap smears in our office at age 21. We used to start it with their first visit sometimes. there's recommendations, and then there are practitioners. We both practice medicine,
right.
And we do see patients that sometimes we're uncomfortable with that recommendation. We have young women who are sexually active at extremely young ages. And worse, if they're sexually active and exposed to the HPV virus, which they probably will be exposed
right.
to, and if they're smokers, they will not shed the virus. They will have the virus dormant, and they will start to undergo cervical change. So smoking, you always think about as being a lung issue, or it's dangerous because of breathing and cancer of the lung. No, it's probably more important to young women to stop smoking now so that they don't develop changes in the cervix that will lead to cervical cancer or repeated cervical biopsies, which may lead to preterm births. Smoking is a serious problem,
right.
even for the young women.
And I think that now that we're more awareness with HPV, that people maybe don't know that cervical cancer is an STD. It's from an STD, which is human papillomavirus, and then you acquire it at a younger age and you smoke. And we have a very high rate of cervical cancer in West Virginia.
And
in
smoking.
young women. And smoking.
Yes.
And two things that now, are really can prevent a lot of things. So Barb is back from Marshall County. You have another question. Hi, Barb. Oh, well, we'll have to. Oh, go ahead.
I'm sorry. I was diagnosed with breast cancer 4 years ago, age 42. I was stage 2, estrogen positive. And my question is, what role does soy play in regard to estrogen production? Because I was told to avoid any soy product. And if you read the ingredients, soy's in everything.
Soy. What's the role of soy? So she has an estrogen positive breast cancer and told to avoid soy.
Well, first of all, there's soy and then there's soy. There's different types of soy, so I really need to know more about that. I would be honest with you, the amount of soy it would take to raise your estrogen level to any appreciable amount, you would have to eat a truckload about every 8 hours, because it is very ineffectual in raising any estrogen. Mm-hmm. I don't believe that if you ate normally and went to the Chinese restaurant and had some bean curd in your
right.
in your hot
would
and sour
okay.
soup, you're
yeah.
jeopardizing your treatment for breast cancer. That would
yeah.
be just silly. So I don't believe that the soy really play any role when it comes to the production of, or the treatment for, or the prevention of treatment for breast
right.
cancer.
Now, what about, we hear a lot about hormones in milk, and is it playing a role in our young women? Are girls going through puberty sooner, or, I guess those are all questions, I guess, as a pediatrician that we get raised. I'm not sure I know the answers to those either.
I must tell you that I think that our food sources, for the most part, are pretty good.
Yeah,
I think that we have a fairly good population, and our government treats milk and meat products, reasonably well. I will say this, that I think that in certain European countries where they're use a lot less pesticides and herbicides and so forth, that people feel better when they don't eat all these chemicals. But I don't know
right.
if we can have a nice randomized trial to prove that some of these things are dangerous or
right.
not. I think I always am envious of somebody who has a nice farm and can raise their own vegetables and their own fruits and maybe have their own cow and their own chickens and eggs. But we can't, and I think that the government does a reasonably good job in protecting us. But I don't know. They are saying that they're seeing puberty earlier and
right.
breast development earlier, and the question is in our food source?
Well,
I don't know the answer.
I don't know the answer. We know the answer to
No.
that either. And we see that I've been around for a while too, and you see these young girls who are developing sooner, and it raises a lot of questions that I don't think we really have the answers to those as to why it's happening. You raise the question, or you talk about West Virginia and the obesity, hypertension, diabetes. You see the high-risk pregnancies, and you see a huge number of women who have these problems. What is the problem in pregnancy?
Well, the problem with the patients, and Stacy sees this in her population as well, and of patients, is that our patients come in that are markedly overweight before they even start the pregnancy. Mm-hmm. And then with this overweight problem, they often have abnormal carbohydrate tolerance, so they wind up with diabetes. and have to be treated in the pregnancy. So it's difficult for them too, because it means more visits, it means more supervision, it means more fetal testing, it's very expensive, and the outcomes are sometimes not 100% good. These patients also have hypertension when they develop diabetes or are overweight. We sometimes have difficulty finding cuffs that are appropriate for their arms to really measure what a normal blood pressure is.
And the high blood pressure is not good for the blood flow to the fetus and the placenta.
Absolutely. Yeah. We wind up doing lots of studies, and when's the opportune time to deliver these patients becomes a serious issue. And the method of delivery becomes an even a greater issue. I was talking to Stacy the other day. We had a patient who was in labor, and she was a very large woman, and the question was, is this baby going to be able to be delivered? How big do you think this child is? And the answer is, I have no clue. It's just impossible to tell. And ultrasound is a wonderful tool, but it doesn't give you the answer.
Right.
It's going to be at least 10% off per kilogram. So if you're talking about a 9-pound baby by ultrasound, the ultrasound is really telling you this baby is either 8 pounds or 10 pounds. Well, I could guess that as well as the ultrasound. Right. So it's not the answer to the size of your baby. And so in these very large women, we have serious problems with this.
Right. Now, what are things that women can do to have a good, successful pregnancy?
I think before they conceive, concentrate on what they're eating, getting foods from all the food groups, having a variety of foods, low carbs, good carbohydrates, also decreasing or stopping, quitting smoking. West Virginia has the highest rate of pregnant smokers in the United States. And we work together, counseling in advance before people conceive so we can have healthy pregnancies. I think women are responsive to teaching, education, and very often I think their health does improve after they conceive because they want to have a healthy baby.
And before you get pregnant, being on folic acid.
To help.
Right?
Yes.
Help reduce the risk of birth defect, neurotube defect.
Our midwifery service, when they see a patient that's coming in for the early visit prior to pregnancy, does such a great job with discussing these issues with the patients before they even attempt conception. If you can get to them before that, you really may make a difference. Early registration for the pregnancy, early visit, that first visit is very important. But the pre-pregnancy visit could even be more important. Right. And so they do such a fine job in the way they distribute their time with these patients that the patients are being reached and understand the issue of folic acid, the issue of calcium, more importantly, the issue of a well-balanced diet, and the importance of exercising and so forth. That we are seeing a difference, right. But it's hard to reach the public.
Right. We have a caller, Judy, in Berkeley County. Hi, Judy. Go ahead. What's your question?
Yes. Hi. I have a sister who had estrogen receptive breast cancer. She also had the BRCA test done, which showed that it was a negative result. And my endocrinologist has recently recommended that I go on Premarin. And I was just wondering what your opinion was of that.
And can I ask approximately how old you are and what decade?
I'm 54.
54.
I also need to know if you've had a hysterectomy.
I have.
If you are symptomatic with vasomotor changes, hot flashes, sleep disturbances, vaginal dryness, etc., maybe difficulty at work because of sleep deprivation, then you would certainly be a candidate for estrogen replacement therapy in spite of your sister's history. And Premarin would be reasonable. There are a lot of other estrogens out there, but you would not need progesterone or progestogen. You would just need an estrogen tablet. If you are just having vaginal difficulties, then you may be a candidate just for vaginal estrogens. But certainly if you're having systemic effects, then you just because of your sister's history, you would not negate you being placed on estrogen for a period of time.
And then be monitored very closely and watch for,
exactly.
for, as you said, in the first 5 years, there really may not be effects, and then you can reevaluate at that time.
Absolutely. You still need your mammograms, of course, every year, right? I know Stacy was going to say that.
Right.
Looking at me to say.
So we have about a minute to go. So what message mammograms. What other message do you have to women to stay healthy?
Self-care, concentrating on diet and exercise, see your provider for any suggestions, annual visits to the healthcare team.
And it's
getting
a team.
The screening test.
So
it is
know
a team.
what you have, know what you're on, know your family history, and you go together and you make decisions together.
Exactly.
Any other last words of advice?
Try to get healthier. You remember, I get upset because, for example, the least expensive food is the worst food.
Right.
To go into a store and buy fresh fruit and fresh vegetables is very expensive. It's a lot easier to go in and get, well, I won't mention it, some chain food that we all, grab some fries and a shake or something. And that's not good, even though it's a lot cheaper. Sometimes you have to spend money to stay healthy, and good food would be important.
And in moderation. So we've been talking about women's health with Dr. Charles Hochberg and midwife Stacy Archer. Thank you both for being with us. If you'd like more information, talk to your family doctor or visit our website at wvuhealthcare.com. For Doctors on Call, I'm Dr. Kathy Moffat. Good night and good health.
Join us again next week for another edition of Doctors on Call. Major funding for Doctors on Call is provided by a grant from the Milan Charitable Foundation. Other funding is provided by the Health Plan, a health maintenance organization serving West Virginia and Ohio since 1979. By the Center for Organ Recovery and Education, supporting Volunteers for Life through organ, tissue, and corneal donation. By Health South Rehabilitation Hospital, serving your rehabilitation needs in Morgantown and Fairmont. And by the faculty and staff of the Robert C. Byrd Health Sciences Center of West Virginia University.
This has been a production of West Virginia Public Broadcasting.